was specifically asked not to talk about my lab research, and so I will be presenting. But if you're interested in what we do, we work in pancreatic cancer, and so there are a couple of reviews that we recently wrote. There's a review by Shields, that's Sharon's scientific grandson, and I wrote a book with, we edited a book with Paul Grippo on the role of tumor microenvironment in pancreatic cancer. But I'll use pancreatic cancer as a model system to look at the issue of metastasis, and we can try to address some of the topics that were covered by other speakers, but from a clinical perspective. I'm sure you've seen this slide before, and you can appreciate that. Here's the incidence of different cancers. Prostate cancer, you can see about 250,000. Breast cancer in that same range. Pancreatic cancer is the 10th most common cancer. It's around 22,000 in men and about 22,000 in women. When it comes to deaths, you're going from the 10th most common incidence of new case of cancers down to the 4th causes. You can see it went from here all the way to there. And most of the deaths that you are seeing here is from metastatic disease. So one can appreciate that part of it. So at any given time, you have about 300,000 and about 300,000 men and women dying of metastatic disease. But I'd like you to also think of it a little bit differently. So here's what I would call the prevalence of disease at any given time. These are the patients who are being actively treated with cancer or are survivors. If we look at prostate cancer, you have about roughly 2.8 million men with prostate cancer who are survivors. So think of it that way. When it comes to breast cancer, about 3 million. On this list, you will not see pancreatic cancer. And you can go down the road, you can see oral cancers down there, ovarian cancers down there. And the reason why we see this discrepancy is that prostate cancer and breast cancer can be diagnosed early and can be cured, whereas most of the other diseases, if you have, as Jennifer showed, that if you have advanced disease, your 5-year survival is not very great. So let me show you another way of showing pancreatic cancer statistics. Here, if you get diagnosed with pancreatic cancer, your survival at 1 year is only 20%. At 5 years, about 3 to 5%. And this has not really changed in the past 50 to 60 years. So look at this is data going back in the 50s, and it's still roughly about the same, 3 to 5%. And even now, even currently, we are still dealing with the same sort of stats for pancreatic cancer as well. So let me present a case, and I think yesterday we heard about Sally Wright dying of pancreatic cancer. I think she was 60, if I remember from reading the newspaper when she was diagnosed, and she died when she was 61 after 17 months. Here's a patient who is 62 years old, presented with vague abdominal pain for a couple of months. She had developed some dark-colored, tea-colored urine, and her skin and eyes had changed colors, become more yellowish. She had lost some weight. Labs were notable for mostly some elevated liver enzymes and a CA19-9. When we look at liver enzymes, we always worry, has the cancer left the primary site? So these are surrogate markers, we think about it. But remember, sometimes if you obstruct the biliary system, that's the thing that drains your gallbladder, you'll also have elevated liver enzymes. So she had an endoscopic ultrasound done, and a CAT scan was also performed on her. Maybe you're not quite familiar with endoscopic ultrasound. The way this is done is that you put a tube into the stomach. At the end there's a little ultrasound probe, and the pancreas sits behind the stomach, and you can at least image it that way. So here's the probe there, here's the pancreas here, here's the tumor there. And looking over here, the probe is here, up there, and here's the tumor there. And through the tube, you can put a needle in it, and you can appreciate that. Here's a needle coming down and biopsying that. So this is an endoscopic ultrasound that is commonly done to see if somebody has a mass, or trying to figure out what exactly that mass is. She also had a CAT scan done. So here's maybe, I don't think others showed CAT scans at all during this presentation. So you're looking at it here. Here are your kidneys here. Here's the back. Here's the front. Here's the liver here. When you see the dark, that's the stomach around there, and some of this is the bowel here. What you're looking here is a mass in this region here, this is the pancreatic mass. So this is a mass that's causing the problem. So if you put a probe here, you could at least biopsy that mass there. So let me orient you again a little bit more about the pancreas, and it becomes important as when you think about in terms of where does the cancers typically end up going. They use the blood system and the lymphatic system. So it's important to know where all of this are. You can imagine if you had something that was distal, say, and the surgeons could completely cut it out, then you can make the patient free of disease. But often, pancreatic cancer will be surrounding somewhere around here, and you can imagine these are the big blood vessels, and if it encroaches and even surrounds the blood vessels, then it will be almost impossible for the surgeon to cut it out. So again, here's your spleen. Here's, you can already just read where the pancreas is. Let me show you if you look at the pancreas again this is looking from the back side. The stomach is now in the front of the pancreas. And you can appreciate all the blood vessels that surround the pancreas. and also appreciate all the lymph nodes that drain the pancreatic bed. So again, the pancreatic cancer, if it's around here, it could spread to other places using the blood system, and also can spread to the lymph nodes in the abdomen. So the first thing that we think about when a patient comes in clinic with a mass, or think about any cancer per se, is does the patient have localized disease or has metastatic disease? So here's in this case of pancreatic cancer, okay, you're suspecting, you go through a couple of studies here and ask the question, is there evidence of metastatic disease? If you have metastatic disease, then it comes down to no local therapy. I mean, it's once the horse has left the barn, so to speak, why go after the barn? So in that case, you think about doing more like a surgical, then you only think about chemotherapy. If there is no evidence of metastatic disease, then the next question is, can the surgeon safely cut it out or not? And this is where it becomes very important to know what the blood system is and where the cancer is going around the blood vessels or not. So if it is resected, if the cancer can be cut out, so the patient will have surgery and will get adjuvant chemotherapy. The idea of adjuvant chemotherapy is that, okay, once the tumor is out, very likely it's a good possibility that some cancer cells have been left behind. Either there's the margin's a little bit positive, or you have some micromets. The idea with that is if you give chemotherapy or something, you might be able to kill those few cancer cells that are still present. So that's the idea of adjuvant therapy. And of course, then the other thing is, well, if we had some chemotherapy, maybe the surgeon could cut it out. That's a borderline resectable. And then the local advanced cancer where the surgeon definitely can't cut it out. And so then you think about more local therapy, and you might say, okay, chemoradiation. And so I'll skip that. You think about the surgery, it's a rather big thing. When it comes to surgical oncology and cancer surgery, the pancreatic surgery is one of the most complicated and most demanding. And so what happens if you have a tumor here in the head of the pancreas, then what happens, the surgeon will come and cut this part of the pancreas, remove some of the bowels here, remove the gallbladder. So that's the cutting part of it. Now, of course, you can't just leave the patient that way. You have to stitch everything up. So now, of course, the pancreas will get stitched up to the bowels here. The stomach will get stitched up to a different part of the bowel here. The drainage. So if you have a mass here and you prevent the drainage, if you block the drainage here, the patient will turn jaundice. Like our patient, she had presented as being yellow. It was mostly because the drainage from the biliary system was being blocked by the tumor. So that will get cut off, and then you have to do all the putting together part of it. So now here's another resectable pancreatic cancer. Again, you can appreciate, here's the liver here, the kidneys, here's the stomach, here's the pancreas. Here's the pancreas, and you can appreciate there's something going on over here. And you can also see there's a little bit of more, I'll call it dilation of the pancreatic duct. So this image, and this is the same specimen. So you can look at it here. Here's your pancreatic duct. Here's a tumor mass here. And because the tumor is blocking the flow of the pancreatic duct, flow from the pancreas, behind it, everything gets backed up. And so that's what you're seeing here in terms of what you're seeing here is this is the mass is there, and that's the drainage part of it. All right, so our patient had a successful Whipple resection. It's a rather difficult surgery. She spent a week in the ICU, a couple more weeks in the hospital, was discharged home. She then comes to see us for more therapy, the idea of adjuvant therapy. And so we decided to give her chemotherapy. And of course, the chemotherapy that we typically use nowadays is gemcitabine. Just think of it as a chemotherapy, and it's an anti-metabolite. It's like the 5-FU that Jennifer talked about it. So again, I would like you to bring to your attention, here's a patient whose cancer was resected. Well, she's technically disease-free. That's the whole idea. But look at it here. So even if from all these are large study, you have about 400 patient study published a few years ago, the overall survival is about only 22 months. Right? If you get chemotherapy. If you just did nothing and just observed the patient, it's about 20 months. I think Sally Ride, she died after 17 months. So I'm not sure whether she had localized disease or whether she had resection. Anyway, even if you had resected disease, median survival is only about 20 months. This particular study established gemcitabine as the standard of care. And of course, gemcitabine was a little bit more expensive. This drug, 5-FU, has been used since the 50s. And so they said, okay, let's do something from the 90s and from the 50s and see which is better. At the end of the day, they're roughly the same. Again, the median survival is about 20 to 23 months. Another large study with almost 1,000 patients. You can also make a case that perhaps if you think about the surgery is technically difficult. The surgeon may not have removed all the cancer cells around it, So let's use another local modality. Let's think about radiation. If you can't cut everything out, if it's localized, perhaps do radiation. If you do that, again, if you do aggressive radiation, again, the median survival doesn't really change by much. You're still looking at around 20 months. If you do, so that's the thing, so it's whether you do chemotherapy or radiation, for these are all for localized disease or resected, you're still only looking at about 20 months. So I can skip that one. So going back to our patient, she comes back, she finishes 6 months of gemcitabine chemotherapy. She presents to her doctors complaining of leg swelling and a little bit of difficulty of breathing. She was found to have a blood clot, and found to have blood clot both in her legs, and then that had gone to the lungs. Again, this time she had elevated liver enzymes, and her blood marker that we use to follow sometimes pancreatic cancer was elevated. Remember, she does not have that, the pancreatic mass is gone, so this liver enzyme should not be abnormal. Like when she first presented, it was abnormal because it was blocking the drainage. But this time she does not have any drainage per se to block, so something else is going on. So she had a CAT scan. Remember, so you can appreciate here. Let's see here. Here's a mass here. Here's another mass here. Again, the kidneys, so you can appreciate so disease has come back and has gone to the liver this time. More examples of disease, of cancer having spread. Here's lymph nodes in the back over here. Also lymph nodes going close to the skin area here in the abdomen. So you've got more lymph nodes. And here's an example of a gross picture of a pancreatic cancer that has gone to the liver. And you can see here's the liver here, and all of this is chock full of mets to the liver. All right. And of course, if you look under the microscope, you may find that you've got disease that has gone to the liver. You can appreciate some of this gland-like structures forming here. This is also gone to the skin area, and again, some of these cells are abnormal. They shouldn't be there, so this has also gone there. And again, here's some most gross specimens of the pancreas. Here's the pancreatic mass. Here's the lymph node here. Let's see. Here's another pancreatic mass. Then you have this is the tail of the pancreas going into the spleen and invading into the spleen and causing a little infarct or death of the spleen. So there's a clot that's preventing drainage. So that's the nature of pancreatic cancer. It's local aggressive. It can spread. It's invasive. So let's skip that one. So the nature of so that was the gross description of what pancreatic cancer it looks like when it has spread to distant places. Under the microscope, here's the pancreatic cancer here. It is invading into the nerve structures here. And for a lot of patients, some of the patients with pancreatic cancer complain of very bad and very severe pain, mostly because the cancer is invading the nerves, and that causes a very debilitating sort of pain. Here, the pancreatic cancer cells are invading to a large blood vessel and causing a little blood clot here. And here is also pancreatic cancer cells invading into the lymphatic system. So you can nicely, I think this particular picture nicely captures invasion into the lymphatics here and also into the blood vessel. I'm sure this slide was shown by others, so I'll skip that one. But the question always comes is that how early does metastasis happen? I mean, so this is a rather interesting paper for the physicists and maybe the mathematicians. So here's a nice paper, Cell published earlier this year. Computational model of pancreatic cancer reveals kinetics of metastasis. Bottom line from this paper is that if you take patients, this was based on data from what I call a rapid autopsy program at Johns Hopkins, where as soon as patients die from their pancreatic cancer, there's a program to collect the tissue, the tumors, and then they can do a whole kind of analysis on it. And based on that, they showed that the probability that metastasis-enabled cells exist at diagnosis is almost 100%, no matter how small the tumor. And the probability that metastasis is present at diagnosis, if you have a 2-centimeter tumor, it's about 40%. If you have a 1-centimeter tumor, it's a 20% chance that the cancer has already left the primary site and has gone to other places. So I'll skip this one. I gather Cal Laban talked about this part here. So again, one aspect is the process of EMT. So the other question, if you look at pancreatic cancer specimens and you say, well, I do see expressions of snail, I see slug, these are EMT drivers. But when you look at this specimen, say, well, I don't see any mesenchymal features to any of these things. They all look very epithelial in nature. Does EMT really happen in vivo? That's always a question. Here's another nice paper published in Cell earlier this year. What they did was they made a transgenic mouse where they created a mouse in which all the epithelial cells expressed YFP. So they can literally track the cells as they change. So what they found is that if they track, because if you look at some of these cells here, this cell here grossly, and that cell looks exactly the same under the microscope. Unless if you do fluorescent microscope, you wouldn't be able to tell whether this cell is different from that cell. Using this particular model, they showed that in fact these epithelial cells are in fact undergoing mesenchymal state, and they're going into the bloodstream, and they can colonize the distant side. Interestingly, they also found that you have all these cells moving out and into the bloodstream very early on in the process. It's not that you have to have a big tumor. Even a very small tumor will have this process happening. And so the other thing they found is that a lot of the cells will, in fact, there are a lot of cells floating in the bloodstream, but the ability to get to a particular site and colonize depends on a few other things. If you have one particular mutation, nothing happens. But if you have a whole bunch of mutations that in a particular cell, when they get to a distant site, they will in fact form tumors. So this is a rather nice paper to at least look at it and think about it. So going back to patients, so the idea of circulating tumor cells. As you think about cells are floating even for very early on, can you capture those cells and at least look at least understand the biology? And there are a lot of technologies out there to isolate circulating tumor cells. One of them is based on flow-based, so this is the circulating CTC chip. Some of it based on size, so if you put them through a filter, they get clogged up. Others are based on an antibody, and then you can pull those down. I think the CCNE folks are using also another approach to look at the gold nanoparticles and flare to isolate circulating tumor cells. And I think the one that's FDA approved for use is called the Veridex approach, where you take the blood sample, and then you can, based on antibody approach, you can isolate the cells, and the number of cells will dictate. One way of thinking of this particular study is that, okay, I look at how many circulating tumor cells are present at, say, after a patient has had the surgery, and then you follow them after 2 cycles of chemotherapy. If you have the same number of circulating tumor cells, you can conclude that chemotherapy is not working. And if you find there is a big drop, some arbitrary number like 50%, 60% drop, perhaps we should continue with that therapy. The other approach is the filter-based approach. Again, you take your cells, you pass it through a filter, and you can get an idea, okay, if the cell gets stuck, then you can stain them. So this is called the ISET approach. And people have looked at whether circulating tumor cells exist in pancreatic cancer or not. There's a lot of images here. I'd rather have you skip all of that. Bottom line is that if you use, depending on the method you use, if you use one method, you get this many circulating tumor cells. If you use another one, you get more of them. There's a paper come out in PNAS recently that showed that they can even detect even more circulating tumor cells depending on how sophisticated the assay is. And that has implication in terms of therapy for patients. If you have no circulating tumor cells, you do a little bit better than if you have circulating tumor cells. Again, this is the world of pancreatic cancer, where this may appear significant. So now the idea is, if there are already circulating tumor cells out there early on, perhaps we should do neoadjuvant chemotherapy. So we talk about adjuvant therapy as well. The tumor gets resected, you come back, and you give the patient treatment after they had their local therapy. Perhaps what we should do neoadjuvant chemotherapy is where you take a patient who has pancreatic cancer, give them chemotherapy, give them radiation, and then if they don't progress, then perhaps only then you should do surgery. That has also been looked at. So this is the largest study I found from the MD Anderson group, and they took about 80 patients. Remember, some of the adjuvant trials, they had like 500 patients, 1,000 patients. The largest study here is with about 80 patients, 86. And they found that they take patients who are resectable, they give them chemotherapy radiation, and they find that as they're going through the process, they count about 11 patients before they can even get their surgery. And then you take those few patients to surgery, and you find they have another 10 or so patients that have metastatic disease. So here's highly selected patients who you think have localized disease, and you go and give them aggressive therapy, and despite that, you find there's progression of the disease. And I'll skip that part. Again, if you think about it, these are cells that are circulating in the blood, right? And so now they get to a particular site. The fate of the cells, once they get to a site, depends on a couple of things. They get to a particular spot, they can either die, they can arrest, or they could form a micromet that's being controlled either by the immune system or not having enough blood vessels. So there's not enough blood nutrition to keep the cells from forming, for the tumor from getting to a certain size. And this is important because we have patients in clinic. We have patients in clinic, or even breast cancer patients, who have had their therapy done. 10 years later, 20 years later, the tumor comes back. We have melanoma patients who had disease resected when in the 20s and 30s, the 50s, when they turn 50 or 60 years old, they have disease chock full in the liver. So very likely, so this idea of dormancy is that something is controlling. In the case of melanoma, the immune system either becomes, the patient gets a little bit immunosuppressed, and as a result, the tumor escapes from the immune surveillance and develops many years later. In other cases, there's an additional mutation happens that causes a change in the angiogenic profile in the surrounding tumor, and now the tumors have more blood vessels growing around it, and you can see many years later. We also have patients with breast cancer patients who have had bone marrow biopsies done for other things 20-something years later, and you find you still have some cancer cells left. We're not entirely sure what to make of that situation. And I think you heard about from Jennifer as to where the tumors end up going. So like breast cancer ends up going to the lung, the liver, the bone, and to the brain area. But for the pancreas, it goes primarily to the liver. And you can argue it goes to the liver because that's where the blood goes. If the blood empties out from the pancreas into the liver, that's where you expect it to go in the first place. And that's true, like colon cancer is like, for example, most of the blood from the colon ends up in the liver, and so that's where you see most of the metastasis happen. Some of the rectal, the more distal area ends up going to the drain into the lung, and that's where we also see some of the metastasis happening. But that's not as simple as that. For like prostate, most of the time we see patients with prostate cancer with bone metastasis. And it is increasingly appreciated. Well, let me take this particular example. So here's another patient that I saw in my clinic, 56 years old, presents with back pain. On a plain x-ray showed there was something, we were worried about metastasis. You get some blood drawn, PSA is a little high, 660. The normal PSA is around under 4. Prostate biopsy, Gleason 5+4. This is aggressive prostate cancer. Bone scan was done, and it shows disease on all. Almost can see this in the spine area, in the hip area, and lots of places. And of course, you can make a case. Well, is it mostly because of blood flow? If you look at autopsies for prostate cancer patients, 90% of the patients have bone metastasis. If you look at the relative blood flow relative to other organs, you find that there's not much blood flow going to the bones compared to the liver or to the thyroid or the kidneys, but you see predominantly goes to the bone. And it is increasingly appreciated. You may have heard Jennifer mention that too, that there's a lot of crosstalk between the cells in a particular spot, like the bone, and the cancer cell that allows the cancer cells to grow at a particular site. All right, so let's go back to our first patient. So here's a patient who had presented with metastatic disease. Remember, when she had resection, she had adjuvant chemotherapy, and then her disease came back. And so she was treated with aggressive chemotherapy, which I will show you what it means. And then she had another chemotherapy. This is first-line metastatic disease treatment. She had second-line therapy, and of course, her disease progressed, and she died 2 years after diagnosis. This is very typical. I mean, Sally Wright died roughly a year and a half after diagnosis. So this is very common that we see in the world of pancreatic cancer. So now, to show you what FOLFIRINOX chemotherapy, this was the most excitement in the last, I would say in the last, I don't know, 20 years when it comes to pancreatic cancer. So if you take advanced pancreatic cancer patients, gemcitabine is very well tolerated. Means I have treated lots of frail 80-year-olds with gemcitabine. I could treat them reasonably well. Trying to treat with FOLFIRINOX is a very aggressive therapy. I've only been able to treat maybe a couple of patients with this regimen, and even then, a lot of them simply refuse to take more than 5 or 6 cycles because they feel so fatigued, so beat up from the chemotherapy. So anyways, this is the best drug out there, this combination. And the important thing is that I showed you early on, the 1-year survival of pancreatic cancer patients about 1-year survival is about 20%. It's the first therapy that improved survival from 20% to 50%. So this is huge improvement. The problem is that trying to treat patients with this aggressive chemotherapy, that's always been, so in other words, you end up selecting only those patients who you think you can give it safely, then it becomes inherent selection bias. This is a clinical trial done in France, and the other thing is they exclude a lot of patients that they only did the tail and the body of the pancreas, whereas most of the patients present in the head of the pancreas. They sent the selection bias that way too. And I'll skip that. So why is pancreatic cancer so difficult to treat? Well, it will come back into redundant pathways. So it means if you block this particular pathway, there's another pathway that may be on, and so you can imagine the tumor cells will just grow. The idea of cancer stem cells, so you could give as aggressive chemotherapy as you want, and if the stem cells are resistant to the standard therapies, So you can imagine if you don't kill the this cancer stem cell, eventually it will come back and start growing again. That's the idea of cancer stem cells here. My lab, we've been particularly interested in the stroma of it, and it's been increasingly appreciated that the stroma, the pronounced fibrotic reaction that's present, limits the amount of chemotherapy that gets to the cancer cell. So perhaps if you can make the fibrotic, make this scar-like tissue more porous, you can get more of the drug to the cancer cells. So that was the basis for using this treatment, gemcitabine and paclitaxel. So this combination, this is albumin coupled Taxol. This particular chemotherapy, at least, is felt to target the stroma. So if you target the stroma, make the stroma, the fibrous, the scar tissue more porous, you get more of the chemotherapy. So this is a phase 1 study, showed that with this combination, you can also improve the median survival to almost a year. Remember, this is phase 1 study. We'll see whether, so there's an ongoing phase 3 trial to figure out whether this is really true or this is, again, a selection bias. Anyway, so that was the area, what happened to a patient with pancreatic cancer. Now let's look at a patient with prostate cancer. I mean, prostate cancer is a hormonal cancer, right? So it requires mostly male hormones. So you can imagine, so he got treated with hormonal therapy. With hormonal therapy, his PSA went down nicely, his back pain improved. We gave him zoledronic acid. That's so that the interaction between these are bisphosphonate that Sharon mentioned. It's the same idea, and that helped with his bones and also with his pain. 2 years later, his PSA started to increase. Again, we gave another therapy that again takes out the male hormones, and his PSA came down. And then his PSA went up again. He was treated with more chemotherapy, and for a little while, again a year later, then it went up. And so you can imagine with prostate cancer, for at least for 5 years, he's doing okay. So and again, this is not the end of the line. So we have a few other drugs we can still give this patient after he progresses on it. So let me just summarize a couple of things. So let's see, if you have the 5-year survival of somebody walking into my clinic is nearly 100% with prostate cancer. 10-year survival, 98%. 15-year survival is 91%. And then if you think about it, it's mostly because if you catch disease early on, if you localize disease, 5-year survival is almost 100%. Regional, it's still 100%. Once the disease has spread to other places, become distant, it's about 30%. If I look at Jennifer's slide, advanced metastatic breast cancer patient was also roughly in 25% range for 5-year survival. So it is not surprising. In the world of pancreatic cancer, so you can see most patients get diagnosed when they have metastatic disease. 5-year survival is 2%. If you have local advanced disease, it's about a third of the patients get diagnosed. About 5-year survival is about 10%. And if you have localized disease, very few of them. 5-year survival is still only about, this is 22%. So it's very likely even the localized patients have advanced, have become metastatic eventually. And with that, I will take questions. Well, I think, if you think about it, most of the patients, I'm not entirely sure what the question was. Let me see if I can address it. In the pancreas, you have got different kinds of cells. You have got the ductal cells, the acinar cells, the islet cells. So most of the tumors that we see are from the duct. And the duct is a very small component of the whole tumor mass. That's what we see in humans. But if you do mouse models, what's been found that if you take the acinar cell, that one that make all this enzyme, that's the majority of the pancreas, if you target particular mutations, KRAS and a few others, and under the right conditions, these acinar cells become ductal. So they call it acinar ductal metaplasia. If you target the insulin secreting cells, the islet cells, under the right conditions, they can also become ductal. So at least in the world of the mouse, if you think in the world of mouse modeling, you could come back and say you can target any cells in the pancreas and eventually, under the right conditions, have them look like ductal tumors. But the right, so if you show the pathologist, they look at the pathology, look at say what? So it's a snapshot. They look like ductal. They have all the ductal markers, so therefore it's ductal. All right. Any other questions? All right, thank you.
All right, so this concludes the workshop unless there is any questions about any of the topics that were presented. I hope, I hope you found this illuminating. I hope it at least gave you an introduction to a very complicated subject, and I hope you see opportunities for the physical scientists to get involved in cancer research, because it's becoming very clear that multiple approaches are going to be needed and multidisciplinary studies in order to solve this extraordinarily complicated process of metastasis and to develop effective therapies for it. So you may be getting by email a questionnaire about the workshop, because we do like to evaluate. We like to get feedback from audience members as to how valuable they found the workshop. So if you get something by email, we would appreciate your responding, and thank you very much for coming.